All right, good afternoon, everyone, and welcome to our session on sexual orientation, gender identity, and diversity and empowerment through mentoring. It's been an exciting morning, and it's going to be a more exciting afternoon. So I would like to, my name is Jo Hawk, and it is not moving. Nathan, I have a problem.
Nathan is here to provide some tech support. So if you go on your keyboard, hit the little right arrow, let me know if that works for you.
I did that, the right arrow, the down button, neither one of them work. Oh, but my mouse does. Okay.
We're in business. All right, continue ahead.
I apologize, everyone. My name is Jo Hawk. My pronouns are she and her. I am a program manager at the Governor's Prevention Partnership, and today I'm going to be the moderator for this session, which basically means I'm going to introduce our wonderful speakers. Today before we go to that introduction, we have a few pieces of housekeeping. We have a session today that will run about 45 minutes. There will be question and answer session towards the end. We are recording this session for future distribution. And a disclaimer that the views presented today are not necessarily the views of the Governor's Prevention Partnership. We are presenting this solely for educational purposes, and the partnership is not liable for any outcomes related to the implementation of the materials presented here today. And with that housekeeping, let me introduce the people that we came here to hear. The first speaker is John Mark Wigington, excuse me for stumbling over your name. He is a PhD candidate in the Department of Health, Behavior, and Society at Johns Hopkins University, and also a research assistant in the Department of Epidemiology at the Bloomberg School of Public Health. His interest is in stigma and trauma, in sexual and mental health, and the sexual and mental health of cisgender, gay, bisexual, and other men who have sex with men, and transgender women. And he has a very interesting presentation today that we will start with. And our second speaker today is Robin McHaelen. She is the founder and former executive director of True Colors. She's authored several books on LGBTQ plus youth and is nationally recognized as a thought leader. She's had several awards. I'm not going to list them all because there are way too many, but the most recent one was in 2019. She received the GLAAD Leadership Award. In 2016, from CCSU, she received an award of Women in Influence Award. She was part of the team that developed the supplement to the elements of effective practice and mentoring for LGBTQ. And she is working with the Governor's Prevention Partnership on a project where we are training and coaching, mentoring staff and coordinators across the state on how to be more inclusive of LGBTQ youth. So with that, I am going to turn over the control to John Mark Wigington, who will do his presentation. Thank you. So I'm going to stop sharing. And John Mark, you can take it away.
All right, can everyone hear me and see my screen all right? Thumbs up, that's great. All right, thank you all for letting me be here today. Again, my name is John Mark Wigington. My pronouns are he, him, his. And today I'll be speaking about some formative research that I was involved in here at Hopkins on leveraging mentorships to facilitate the sexual health of Black, sexual, and gender minority youth at risk for HIV. give some background first. So as you may or may not know, young Black, gay, bisexual, and other men who have sex with men and transgender women are disproportionately burdened by HIV and have been for some time. Sexual health disparities such as this are underpinned by and exacerbated by social and structural conditions such as racism, homophobia, transphobia, and so on. Given what we know about the benefits of mentoring, we conceive that mentoring could perhaps be leveraged to mitigate the impact of these conditions to some extent and improve sexual health outcomes for this population. Though there are a few mentoring programs that are tailored specifically to sexual and gender minority youth, particularly sexual and gender minority youth of color. In addition, given what we know about Mhealth interventions, for example, they have been shown to be effective in promoting health among Black, sexual, and gender minority youth. We conceive that they could also be a valuable tool to perhaps support mentors and mentees in addressing sexual health issues. And so given this background, for our formative research, our objectives here were to explore the role of mentoring relationships in the sexual health of Black, sexual, and gender minority youth, and how these relationships may be strengthened to promote HIV prevention, particularly via mobile technology. So the settings for this research were Baltimore, Maryland, Washington, DC, and Philadelphia, Pennsylvania. And we recruited both mentees and mentors as participants from LGBTQ+ organizations, from mentoring organizations. And we also utilized more passive recruitment methods, such as like making social media posts, handing out flyers, things of that nature to get additional participants. Our eligibility criteria for our mentee participants involved identification as Black or African American, being assigned male sex at birth, and currently identifying as a man, woman, or a non-binary person. So in other words, cisgender men, transgender women, trans feminine persons, and non-binary persons were eligible to participate. Our age range for our mentees was 15 to 24 years with a sexual interest in men, and those who had had a non-familial adult mentor for at least 3 months at the time of recruitment. For our mentors, our recruitment criteria included being age 18 years or older, and serving as a non-familiar mentor to a mentee, to a youth mentee who met these criteria here, and who had done so for at least 3 months. And just to note, our mentees and mentors didn't have to be matched to one another to participate in the study. That kind of incidentally happened in a few instances, but that was not required for participation. To collect our data, we conducted in-depth interviews with our participants, and we used a semi-structured interview guide to do this. For our mentees, we discussed things like their relationship with their mentor, the extent to which sexual health discussions occurred with their mentor, and any tips or advice from the mentee's perspective for mentors on how to better address these types of topics. For our mentors, we asked questions related to kind of how they perceived their own role in sexual health discussions with their mentee, the sorts of knowledge that they had regarding sexual health, their confidence in mentoring regarding these issues, and finally, what they perceive to be as barriers to having these types of discussions. And given that this was formative and driven by the idea of a mobile health application, we asked everyone whether and how a mobile application might help facilitate mentoring on sexual health topics. And we, of course, recorded these interviews, we transcribed them, we coded them, and then conducted an analysis on all of our data. So I'm first going to present some of our sample characteristic results, and then later I'll get into some of the themes from the interviews. So as you can see, most of our mentees actually came from DC, about half. And our mentors were kind of equally spread between Philadelphia and DC. And interestingly, even though we were based in Baltimore, we had a pretty difficult time recruiting mentors and mentees here. And most of our mentees and mentors identified as cisgender men or cisgender males, and followed by trans women and non-binary persons. So about a third of our mentees were aged 15 to 19, and the other 2/3 were 20 to 24. If you recall, the cutoff age for the mentees were 20 to 24. And so this 29, going up to 29 here relates mostly to the mentors. So most of our mentors were in their 20s. And here are a few mentorship specific characteristics. As you can see, overwhelmingly, these were naturally occurring mentorships. There were very few mentees or mentors who were part of formal mentoring programs. And most of these mentorships had been ongoing for 1 to 2 years or longer. And settings where these naturally occurring mentorships tended to originate often included the house of all community, as well as high schools, for example, maybe teachers or coaches, pride events, just other individuals in participant social network. So we found 4 major themes in our interview data. The first of these themes is sexual health as a commonly discussed topic. So it seemed that sexual health discussions were particularly common in mentorships that were that had lasted a bit longer, that were more naturally occurring. And our participants who were involved in more formal programs said that either some of the programmatic goals of the organizations they were a part of, or just other restrictions in the programs they were a part of kind of prevented them from their perspective from being able to have sexual health discussions with their mentees. But among those who did have these discussions, they were usually initiated by the mentor, but they were often accompanied with reluctance and discomfort on the part of the mentor. For example, this mentor from DC said, I don't want mentee to be like, why are you asking me questions about HIV? I'm comfortable with having a conversation about sexual health, but I don't want mentee to look like, why are you asking me that? And so I think this also probably touches a little bit on a lot of the stigma that still accompanies HIV. So from our mentees' perspective, these sexual health discussions tended to occur whenever the mentee may have been discussing their own romantic relationship or a recent sexual encounter they had. From the mentor's perspective, these conversations arose because the mentor maybe observed something that they perceived to be a sexual risk factor in their mentee. For example, maybe having sex with multiple partners, maybe having condomless sex or something like that. From the perspective of both mentees and mentors, these discussions tended to be embedded in kind of broad topics focused on sexual health, like healthy dating, communication in relationships, things like that. They seemed rarely to be focused directly or zeroed in on the actual risk behavior of the mentee. And the second theme that we pulled out of the data was kind of positive attitudes toward these sexual health conversations, but really limited sexual health knowledge on the part of the mentors in particular. So for both mentors and mentees, they described these sexual health conversations relatively positively and indicated these were positive experiences for them. And they seem to really be built on trust, as indicated with this quote here from a mentor in DC. You know, what's really challenging is when you can see mentee engaging in sexual risk behavior without mentee knowing that you can see. You still have to remain neutral. I feel like mentee and I have a trusting relationship, so I don't think I would be afraid to bring it up. If we didn't have that trust, it would be a different story. And so in addition to trust, we also saw that there were some mentors who really described this sort of persistence in trying to address sexual health with their mentee. For example, this mentor from Baltimore says, "I've talked to mentee multiple times about PrEP." And just a side note, for those of you who may not be aware, PrEP stands for HIV pre-exposure prophylaxis, which is Truvada, which is a medication you can take daily to prevent acquisition of HIV if you're exposed. So this mentor says, "I've talked to mentee multiple times about PrEP, and did mentee take the advice? I don't know. But since I'm aware of mentee's behavior, I was like, I'm gonna at least give mentee the information. You can prevent yourself from getting HIV if you take your PrEP every day." Mentees described being fairly receptive whenever their mentors would bring up sexual topics or sexual health topics. But the mentors overwhelmingly felt that they really couldn't provide much detailed information due to their own lack of knowledge. And we didn't find any instances of the mentors actually referring their mentees to a sexual health service provider or any sexual health services. Mentees described a lot of trust and confidence in whatever their mentors said to them about sexual health, even if it caused embarrassment, as they really believed that their mentors had their best interests in mind, again, showing the importance of trust in those relationships. But again, the mentors, as indicated with the previous theme, the mentors tended to be more comfortable discussing romantic relationships or healthy dating more broadly, but felt ill-prepared otherwise or uncomfortable bringing up risk behaviors. And a lot of them specifically noted that beyond saying things like you should wear condoms, they really didn't know what they could or should say or discuss. The third theme was personal and interpersonal factors tend to shape these dynamics between mentors and mentees having these conversations. So for example, we found that mentors with greater in-depth knowledge about HIV tended to be those who were living with HIV themselves, those who had a partner living with HIV, or those who were members of the LGBTQ community. So for this mentor from Philadelphia says, "We talked about, HIV status. I had wound up finding out not too long before that I was positive. And when I was young, I didn't have the luxury of having that much insight into the do's and don'ts of how HIV is transmitted. Because of my status, I did my homework. And so I know what to say when I talk to mentee about it." The mentees kind of described how they had these more in-depth discussions about sexual health, and they tended to emerge among mentees who had these kind of longer, more trusting relationships with their mentor. And likewise, mentors with more HIV knowledge were therefore a little more comfortable having these in-depth conversations about HIV and risk reduction strategies with their mentees beyond embedding them in more general conversation. In addition to having trusting relationships with their mentor, mentees reported that having mentors who had experience with the LGBTQ community or who identified with that community, having mentors who had maybe discussed HIV with them previously, or having mentors who the mentees assumed had maybe had their own sexual experiences from which to speak of, these factors tended to support having had deeper conversations about sexual health. Mentors who belonged to the LGBTQ community, they tried to stay up to date on PrEP and seemed a bit more knowledgeable about PrEP, although they tended not to have detailed conversations about it with their mentees. So they may have just stayed up to date on this information for their own health and that of their community, but for whatever reason may have felt less comfortable or less prepared to discuss this with a mentee. And the final theme is that Mhealth tools could potentially support mentees' sexual health. So a mobile health app to share knowledge, share resources, and to facilitate conversations on sexual health and HIV appealed to all of our participants, mentees and mentors alike. For example, this mentor from DC says, the app sounds like an important thing, like someone to remind you that, hey, you have to go to your doctor's appointment today. Or there's these new condoms. Did you get these? Have you seen these? There's a new transgender group going on. I think you should attend. Maybe you want to check it out. So those things on the app would probably make it easy to use. But ensuring that the app could be used discreetly was mentioned by several participants, especially mentees. For example, this mentee from Baltimore said, I feel like a lot of people want to do stuff like test for HIV, learn about PrEP secretly. So it would be good if we could learn about it without everyone knowing. So as that quote reflects, the mentees wanted an app that could link them to sexual health services discreetly. Our mentors wanted an app, for example, that might have something akin to a forum where mentors could talk to one another, where they could share information with one another on various issues faced by their mentees. For example, a lot of mentors mentioned that beyond HIV, there were other things that their mentees face that it would be helpful for them to know about, such as other chronic health conditions, day-to-day survival needs, mental health needs. Mental health in particular was emerged quite a bit, even though this was focused on sexual health. From the mentee side, mentees also wanted an app that kind of had a little bit of fun and humor to go with it, such as a lot of mentees mentioned things like, emojis or memes, GIFs, things like that they thought would be make the experience a bit more fun and would be more appealing to folks their age. And in addition, mentors wanted something in the app that would kind of provide some means of self-training or skill building to help improve their mentorship of mentees who are part of this population. There are a few limitations I want to note. We had a small representation of mentors and mentees from formal programs, as you saw. And some of our informal discussions about this with community members indicated that some of this was due to some distrust of formal mentoring programs by Black and sexual gender minority youth. Our recruitment was done primarily by word of mouth and advertising. So our sample is, of course, not very representative of mentoring relationships in these settings. Our eligible mentee participants are a bit older than maybe those that are typically discussed in a lot of the youth mentoring literature. So that may make it a bit difficult to contextualize our findings or compare our findings with some of this prior literature. And finally, participants who were transgender women were all recruited from a social support organization addressing youth's basic needs, which may account for why for these participants and their mentors, basic needs were the primary focus of their mentoring relationship rather than sexual health. However, this does align with a lot of other research out there on trans women of all ages that reflects just really pervasive barriers to accessing resources and basic needs. There are a few major takeaways I want to highlight before wrapping up. First, naturally occurring mentorships are very important for Black, sexual, and gender minority youth. And from our sample, they're already characterized to varying extents by sexual health discussions, which highlights a real opportunity for sexual health intervention for this population. Some of our mentors lacked comfort and or knowledge about HIV and other sexual health issues, but we're hopeful that an app could address these barriers. So sexual health training and resources for mentors are needed. Some mentees felt an app that could be used discreetly could help them comfortably connect to sexual health resources. Just kind of reiterating the importance of respecting and addressing privacy concerns for young, multiply marginalized groups. Mentors that have some sort of shared experience or identity with their mentee may be better positioned to address delicate issues such as sexual health. So trust may be the most important factor. And finally, sexual and gender minority youth contend with numerous other issues aside from HIV and sexual health that become intertwined with sexual health. And so the utility of an Mhealth mentoring intervention will be maximized only insofar as these other needs are met. I just want to acknowledge our partners and contributors, consultants, and funders. And I thank you. And this is my email here at the bottom. And this is Michelle Kaufman's email, who is the PI of this project and other studies related to this work.
And certainly they can contact me and I would be glad to connect them with you. Thank you very much, John Mark. Can you please, yeah, thank you. I want to move quickly to the presentation that Robin will give. Let's see if I do this correctly from the slide. All right, do you see the screen?
Yes.
Okay, fantastic. Just tell me when you would like to
Go forward.
Yeah, of course.
And again, go forward. So I want to say sort of before we start that, I was saying to Joe last week when we were talking about this, that, John Mark's work was done a lot with Black sexual and gender minority youth. And my conversation is going to be about using intersectionality around mentor relationships and how intersectionality needs to play a role. And I just want to notice that we're sort of both white presenters. And so I would really invite people, especially as I go through this part about this tool that we developed, that I developed for the Human Rights Campaign, I would really invite people to comment, make corrections, challenge any parts of it, especially those with a different lived experience. So I just want to sort of put that out there. Intersectionality, we only have a few minutes, so I don't want to spend a lot of time on this, but I do want to say that intersectionality was created, the concept was created by Kimberly Crenshaw, who noticed that a couple of things. One, that if you don't have a name for something, a problem, then the problem doesn't exist. And most of her initial work looked at the intersections of race and gender for African American or Black women. It's since expanded to include a lens that looks at all of the different social identities that people have and the recognition that what combination of social identities we have impacts our experiences in the world. And when we have multiple social identities that are marginalized by the larger community, that dramatically impacts our experiences in the world. In John Mark's presentation, he noted that Black, gay, sexual minority, and gender minority youth are distrustful of mentoring programs. And that's an important piece, and it probably has something to do with institutionalized racism and institutionalized, sort of the systems that are in place. So there's a lot of white leadership in many of these programs, and so we can only see, through the lenses that we have, and that may impact the experiences of the young people that we're serving. So this is just a quote from Kimberly Crenshaw. And thanks.
I'm sorry.
Good. Next one, Joe. Okay. So I think that when we're talking about the youth that we serve, and I've supposed, the work that I've done for all these years has really been about LGBTQ plus youth. And so a lot of the conversations have been that, that LGBTQ plus youth are not just LGBTQ, or white. They're all of these other things, and we need to pay attention to them. And that, there's lots of different ways of looking at dimensions of identity. I love this little slide because it shows, on the left side, it's sort of what they call SOGI, sexual orientation, gender identity, and expression. But there's also race, ethnicity, ability, language, class, faith and spirituality, geography, education, citizenship status, documentation, all of those things. And then there's all of these systems of oppression, ageism, adultism, cissexism, all of those systems of oppression that marginalize folks and impact their experiences in the world. So intersectionality is a theory of oppression that guides our work to support clients. It asks us to consider all aspects of the client's identity. So we put together a tool for a program that we was doing with the Human Rights Campaign that it was really designed for social workers who are in the child welfare system. And so it'll need to be tweaked a little bit around mentoring, but the idea is to give people a tool or some ideas for how they might think about what questions you should be asking. How do you think about intersectionality when you're meeting a new mentor, when you're meeting a new mentee, and specifically when you're considering the matches that you want to do. That John Mark's research also showed that there was a lot better connection and a lot better communication and trust when people came from sort of shared identities. And so I think that's a piece of it. Next slide. So this, and I know these slides will be made available to y'all, that if you click that handout, that intersectionality handout, that there's at HRC, they put together an intersectionality vocabulary, which is just sort of useful, especially for people who are new to the concept. And we put together this intersectionality worksheet. And so I'm going to take you through the 3 parts of the worksheet relatively quickly. And then you have access to it. You can download it using that clickable link. You can download it and then use it while you're thinking about the young person that you're meeting or that you're serving. Next slide. So, oops. Okay, so I think it's the next slide, Joe.
Oh, I'm sorry. I'm using my mouse.
There you go. Okay, you got it. So step 1 in the tool is really thinking about what are all of the different levels of identity that this young person or the mentor, depends on which one you're looking at, is going to bring to the table. And so you want to start by, if you have access to the youth's records, start by mining their files. What elements of their various identities can you determine before you even meet the young person? That's helpful because it begins to give you some idea about what are some of the questions you might want to consider, what are some of the topics of conversation, and what are some of the barriers that your young person might be experiencing. And I also, this one doesn't include it in here, but if you're working with a young person who's in a juvenile justice or foster care or a group home, that creates another level of stigma that is sometimes even more powerfully stigmatizing to the young person than their identity as an LGBTQ plus young person. So, and then also consider their economic status and their access to resources as part of it. And so this, review the files. What identities can you identify from your client's files in terms of these areas of their identity? And there may be others as well. And so next slide. And that as you are thinking about, before you're even meeting with the young person, really thinking through what are some of the potential intersections? That systems of oppression cause people with marginalized identity to be subject to significant additional stress, discrimination, and harassment, okay? So which of your child's identity, your client's identities might put them at higher risk of experiencing this kind of minority stress with their bio family? So their LGBTQ plus identity could be a source of minority stress with their bio family. With their foster family, do they share the same racial or ethnic identity? Do they share the same religion? Do they share the same, are they going to be the only person in the home with a sexual or gender minority identity? Is there racial congruity, language congruity in the home? In their schools, what kind of diversity exists in their schools? Are they documented? Is English their first language? Do they have an IEP or a specialized learning program? Do they have a learning disability which can help ostracize them? And are they connected with any other systems where they may also be experiencing marginalization, such as juvenile justice, ICE, and other programs? Great, thank you. Next slide. And then as you're working with the young person, obviously you're not going to go down this list and just ask them all of these questions, right? But these are some questions that you can begin to think about that allows you to move deeper into your relationship with the young person and to recognize and allow them to bring to the table all these elements of their identity. So, for example, there's so much going on in terms of Black Lives Matter, in terms of all of the issues that happened over the summer, in terms of the stuff that happened at the Capitol. There's all these things that are happening, and those things that are happening impact, people in the society. So saying, if you've identified that a kid, is a racial or ethnic minority, to say something like, hey, there's a lot of stuff going on in the news these days. How is that impacting you? What kinds of things are you doing to take care of yourself? One of my friends said, and I thought this was a really cool phrase, she doesn't ask, how are you, if she really wants to know. Because how are you is that thing like, what are you supposed to say? When someone says, how are you? You say, I'm fine, thank you, how are you, right? But so when she wants to actually know, she says, how are you maintaining? Right? And that because she wants to know, how are you taking care of yourself in all of the stuff that's going on with COVID and racism and white supremacy and all the things that are happening. Here's a question. Our team is looking for, and this one says potential foster parent, but we used to do this with our mentors in our mentoring program. I have to describe you to a potential mentor. What do you want me to say, right? How would you like me to describe you? Are there any things about you that you would prefer that I not mention? Is there anything that you were worried that they might have a weird response to, or that they might have a bias about, right? So that you're asking questions that allow the young person to explain and express and be like a whole human. That your foster parent or your mentor comes from a different racial or XXX background than you. How has anything come up between you around that? What's that been like for you? Are there any times when you felt unheard or disrespected because of that difference in your identity? Most people have privileged and marginalized parts of their identity, and most of us need an ally at some times. Who have you been an ally for? Right? And what was that like? So that these are ways of taking the questions in, and I apologize, I'm working from home and the phone is ringing, that just allow people to get into deeper conversations. Someone noted in the comment that these questions can also help students reflect on emotions that they might be feeling, which is great. And last slide, because I want to leave a couple minutes for answers. Final thoughts: stay open and curious. Listen to understand rather than be understood. Accept and respect even if you don't understand or approve. Because the reality is, if you don't have the identity, the combination of identities that the young person has, no matter how much empathy we have, we can't fully know what it's like to walk through the world in their shoes. So accepting and respecting their perspective, their identity, and the words that they use are just the first step. And then recognize, lastly, that oppression is the problem, not the youth. So if the youth is experiencing issues, it's not the youth's fault, it's the oppression that's the problem. Okay, I am done. We have, I think, 3 minutes. No,
Unfortunately, so much good information. Let's take about 3 minutes for Q&A, and then we have a closing slide or two. Okay. I'm going to leave it to Robin to.
Okay. And if there's anybody, I can't see everybody. So if you want to put it in the
chat
box, or you can unmute yourself, I think.
Yes, you can.
You can just ask the question. So we've got a couple minutes. You can ask me or Mark, John Mark, anything that you'd like, or comment.
Yes. I know Patty has something to say.
You're so funny, Joe. No, I'm trying to be quiet. You guys said it all. That was very informative. I've been in the community for a long time, but you know, I always get something out of these. And Robin, those are awesome tools. You know,
good. I'm glad you
really use on so many levels. And John, your amount of research is just amazing. Oh my gosh, very impressive.
And really cutting edge, looking at the app and so forth. It's really and different from a lot of the discourse that we have around mentoring. So I was really pleased to have his presentation.
And I'm not sure I'm going to say your name right, but Edie said, is Mhealth a free app service? Correct me on your name, the pronunciation of your name.
It's pronounced Adia, but that's okay. Thank you.
Okay, Adia, thank you. So Adia wants to know if Mhealth is a free app or service. John Michael, that one's for you.
So the mentoring app is not yet available. It's currently being pilot tested. We were delayed a little bit because of the pandemic, but we expect the pilot testing to likely wrap up this year. So hopefully, once we can wrap that up, we can roll it out. And as far as I know, it will be free and freely available. You can touch base with us via email in the future to kind of get updates on that.
Fantastic.
Thank you.
Thank you. All right.
All right. Well, let me remind you that we're not done with the summit. We have a couple more sessions this afternoon. One of them is the closer for today, focuses on emerging technologies for mentoring. So there'll be more information about other apps that are available. It's the new trend, and I think we're going to have a lot of great tools in the future that mentors can use. We have some games, I believe, that our friend Nathan here is going to show us some really exciting things that are available for mentors and mentoring programs to use. And before that, we have a couple more sessions, one of them on virtual mentoring. It got really picked up a lot over the last year as we had to deal with COVID and the situation. So there are a lot of new issues that arise, and so there's and opportunities also that have come to the foreground. So don't miss that one. And if you're interested in how to use data, we got a session on program evaluation. It's really geared towards mentoring providers who may fear data a little bit for a variety of reasons. There ain't no reason to. So we're just going to, talk a little bit about how do you use program evaluation to empower your programs. And tomorrow we have another fun-filled day with a couple of great speakers. So we look forward to seeing you on Zoom throughout today and certainly tomorrow. So don't forget, okay? And thank you so much, Robin and John Mark. You did a great presentation. I wish we had another hour because I know that with another hour, we could have really gotten into a lot more discussion, and there's so much to be learned. So thank you so much, both of you.
Thank you very much. It was fun.
Thank you.
Thanks.
All right. Take
John
care.
Michael,
All.
that was great. Thank you so much.
All right.